thank you. So today I'm going to be presenting on the first component of a project to develop AI-augmented HCV surveillance. So this initial component is a proof of concept to see if it can be done, see how well it works, and then think about how we can expand this moving forward. So monitoring HCV treatment, reinfection, treatment failure, and retreatment among key populations of people who inject drugs and people in prison is critical to support elimination efforts. So currently in Australia, there are no national HCV surveillance systems with this capability. So this presentation will cover the HCV surveillance data that we already have, how we can use AI to enhance this data, how well does this work and what does it tell us, and then challenges and next steps. So what do we have? In Australia, we have a National Notifiable Diseases Surveillance System, and this reports every HCV positive test from pathology labs around the country. Limitations of this are that these are mostly HCV antibody notifications. So what we're recording in this is exposure, not actual infection. So the notification can only be made once, and there's no way to look at things like spontaneous clearance or reinfection. Then we have pharmaceutical dispensing data. So this data reports every DAA treatment and retreatment that is dispensed from pharmacies around Australia. So it includes data on the DAA, the patient, the prescriber, and some demographic details as well, but it doesn't report reason for retreatment, whether this person has recent injecting drug use, or whether retreatment is occurring in prison. So from the data that we have, what do we already know? So around 106,000 people have been treated in Australia, and looking at this figure here, you can see the treatment numbers have been declining over time. But what's been increasing is the number of individuals retreated and the number of multiple retreatments. So 10% of our population have been retreated at least once. That equals around 13,500 retreatments, and by 2023, 1/3 of all DAAs dispensed in Australia were for retreatment. So what do we want to know? So we want to know information that's going to help support health systems, evaluate HCV interventions, and guide the allocation of health resources. So the aims of this study were to develop AI-augmented HCV surveillance to track reason for retreatment, so whether it was reinfection or treatment failure, retreatment in prisons, and retreatment by recent injecting drug use. And for this component of the project, I'm going to be using machine learning, which is a subset of AI, and I'll be using those terms interchangeably. So for the study design, PHASE, or Pharmaco-AI Infectious Disease Surveillance Study, is a project I developed to advance Australia's population-level data analytic capabilities. So this project was developed in part due to the creation of this new national data asset. So in the figure there, you can see all the different data sets that are linked at a national level. So this is de-identified data for 37 million people with over 15 years of follow-up that is continuously updated over time. So for this particular study though, I'm going to zoom in and pick a very specific population and focus on this one data set to see what we can do with AI to enhance this before expanding into the rest of the data. So I'll be using the pharmaceutical benefit scheme data and people treated for HCV between 2016 and 2023. So just quickly, how do we develop these AI models? So the first step, gathering data, sounds the easiest, but is probably one of the hardest steps. So we need to get data that is relevant and representative for the predictions we want to make. Next is feature engineering, so cleaning, encoding, scaling, and transforming the data so it's in a format that helps the machine learning model learn patterns. Next, model training, validation, and here we tune the hyperparameters and optimize the model performance. Finally, testing the model. So in this stage, we test the model on data it hasn't seen before to see how well it's working. And this is not a static state. So generally, you'll go around this cycle because as things change over time, you need to keep bringing in more data for that testing and calibration to make sure that the model is working well and the findings are robust and reliable. So, model number 1. Retreatment reason. So for this model, we used a machine learning classifier. It was trained on national standard of care data that was representative of treatment and retreatment in Australia. The sensitivity of the model was 96% and specificity was 97%. We then applied this to pharmacy dispensing data to classify reason for retreatment. So going back to this figure again, where we've got our treatments and our rising retreatments in the purple, zooming in on those retreatments, we can see there is a trend there, but we can't tell what's going on with treatment failure and reinfection. We apply the model, and now we can see retreatment for treatment failure, there in the pink, has a little bit of a peak when a new salvage DAA was listed on the pharmaceutical benefit scheme. And then retreatment for reinfection, which is comprising the bulk of retreatments in Australia, has had a bit of a plateau around COVID when there was decreased reinfection surveillance and detection, and then post-COVID we're seeing quite a steep increase. Now we can also look at where the multiple retreatments are coming in. So of retreatments for treatment failure, around 18% were multiple retreatments, and that's increased very steadily over time. Looking at reinfection though, 24% were multiple retreatments, and this is increasing quite considerably over time. Next was a model for retreatment in a prison setting. So this model was a little bit different to the sort of process that I outlined earlier. This is an unsupervised model that's developed directly on the data. And what it does is identify patterns in the codes. And the reason I sort of applied this model was, 1, to see if it worked, and 2, I knew that there were some patterns in there that were indicative of prison prescribing. So after I created this model, I was able to test it on some linked data that did have prisons available and could see it was working very well, so 94% sensitivity, specificity of 91%. So when we look at the prison treatment trends, we're seeing an increasing proportion of initial treatment delivery in prisons. So it's risen from 4% in 2016 to 33% in 2023. Treatment failure, around 17% occurred in prisons, and quite often this was following treatment discontinuation. For reinfection, around half of all retreatment for reinfection was being delivered in prisons. On to our next model, which is Model 3, recent injecting drug use. So this was a supervised machine learning model that was developed on this large standard of care data set. I didn't expect this model to perform as well as the others. That's simply because the variables that are available in the PBS and the data that I have were very difficult to use to predict injecting drug use. So it worked. The specificity was quite good, 89%. The sensitivity was a little bit lower at 78%. So when we applied this model, we can see that there is rising treatment uptake rising proportion of treatment is among people who inject drugs. So it's increased from 5% in 2016 to 56% in 2023. Looking at treatment failure, 51% of retreatment for treatment failure was among people with recent IDU. And this seems quite high, but when we look at the data on treatment discontinuation, we're seeing an increasing trend over time. And among people who inject drugs, the majority of retreatment for treatment failure was following treatment discontinuation, so missing at least 28 doses of treatment. Finally, reinfection. So almost all retreatment for reinfection was among people who inject drugs. So this is what we would expect to see, and so there is a little bit of uncertainty, the model specificity and sensitivity sort of being a little bit lower than what we'd want, but hopefully we can improve that in the future. So next steps are to bring in the rest of that data that's in that huge data linkage. So looking at HCV RNA testing, estimating national reinfection trends, looking at health utilisation patterns before and after treatment, and assessing health trajectories among people with hepatitis C, and then looking at socioeconomic impact, socioeconomic factors and how they impact health. Then expansion beyond HCV to other health conditions and infections. So the challenges. So with machine learning, the model testing and ensuring that these predictions are accurate is always a challenge. So distribution shift may occur, and what this means is the data, real-world data is changing over time, and it's different to the data we developed the model on. So we need to constantly be gathering more data for testing and calibration, and this is really challenging and resource intensive. In terms of resources, big data analytics and AI require substantial compute resources, and these are expensive. We also require very specialised data science and data engineering skill sets. So these are hard to get in academia. They're skill sets that are very undervalued in this setting, and there's very few people with the cross-disciplinary skills. For translation, it's great that we can sort of build all these models, but then we need to think about how can they work to benefit the population. So how can we engage with community, government and health services to make sure that the models that we're building are robust and reliable and benefiting people, and making sure that data security, privacy, fairness and trust are maintained. So in summary, when we applied machine learning models to national level administrative data, we found that reinfection is driving increases in retreatments in Australia. Prisons contribute substantially to HCV treatment and retreatment delivery. Most retreatment was among people with recent injecting drug use, so almost all reinfection and a substantial proportion of treatment failure. But we did get our proof of concept demonstration. So AI-augmented HCV surveillance does hold promise, but there is a lot more work to be done. Thank you.
Thank you, Joanne. Stay there in case somebody wants to ask you a question. Is there any questions on the floor? I was just wondering, while somebody gets the mic, I was just wondering, do you need more? I was expecting you'd need more than 350 retreatments to train a machine learning algorithm. I was just wondering if you want to say anything about that.
Yeah, so I was surprised about how well that worked as well as you. So I've done some validations on different data sets, cohort data sets, different cohorts, and it does seem to perform quite well. And I think the reason for that is that there are very clear sort of prescribing patterns in Australia. So now we only have 2 first-line regimens, Glade-Pib and Soft-Vel, and then we've got Soft-Vel-Vox for treatment failure. So when we're incorporating all these other factors, prescriber type, whether someone completed treatment or not, the geographic location and all these things, they are quite distinct, the patterns. So I think that's why it was probably an easy problem for the machine learning algorithm to solve. And if you used maybe a more traditional statistic approach, you could probably also achieve fairly high sensitivity and specificity.
Thank you. Has anyone got a quick question? Oh, one here.
Yeah, hi, Martin Kåberg from Sweden. I have a question. Could you elaborate on how you defined injecting drug use and current injecting drug use from all your data sets?
Yep, sure. So the current injecting drug use was injecting within the past 6 months, and that comes from that real-world standard of care cohort. So that was at the time point they initiated treatment or retreatment. So either the clinician got it from medical records or they asked the person. So it was mostly self-reported or clinician reported. So that's how it was defined. So again, it's imperfect, but it really is so challenging to get data that has the variables that I need, that is the size that I need, that I can build these models on and then apply to, you know, data that's similar, the PBS data, to get predictions.
No.
Unfortunately, we don't have time for more questions, but you can find the speaker after the session. Thank you so much.
Thank you.